to this BMJ Best Practice podcast on syncope. Kieran Walsh is my name, I'm clinical editor at BMJ. Syncope is common. It accounts for approximately 1% of all emergency department visits and 2% of hospital admissions from the emergency department. The cause can be innocent, but can also be life-threatening. Causes include dysrhythmias, pulmonary embolism, subarachnoid hemorrhage, and acute coronary syndromes, to name but a few. So it's important that we get the diagnosis and management of this condition right. To give us
Yeah, then it's worth doing a CAT scan of their head. Patient comes in and they're having pleuritic chest pain and tachycardia. Then it's worth investigating for concomitant pulmonary embolus. And the same is true with cardiac enzymes. Patient comes in and there's history suggestive of myocardial infarction. Yes, absolutely, they need myocardial. They need a troponin. But beyond that, testing becomes far more limited and far less useful.
Okay, thank you. What are the common pitfalls in diagnosis?
And what people often will do is they'll say, okay, the patient has syncope, and syncope, it looks life-threatening. And patient, you appear dead with a syncopal event. So that means that if you're dead or almost dead, well, then you automatically need an admission to the hospital. You automatically need that big workup we talked about. But that's generally not true. What we often do again is overtest. We often say, well, if just because the patient's elderly, all that, then they're at risk for an adverse event with syncope, rather than looking at the patient themselves. The initial manifestation of syncope of structural heart disease in the elderly is not syncope. The patient is not going to have their first MI unless they have symptoms of an MI with a syncopal event. They're not going to have their PE without symptoms of PE, with just having syncope alone. So we're often trapped. We say, this is a 90-year-old patient who came with a syncopal event who has no cardiac history and nothing that should suggest that this was something dangerous. And we say, okay, well, now we need to admit them to the hospital and put them through everything that patients undergo when they're hospitalized. So, they're at risk for nosocomial infections, at risk for sundowning and delirium. And yet the patient really is absolutely fine if you look at 30-day outcomes. And the patient really didn't need hospitalization if your workup was, your evaluation, your history didn't reveal anything worrisome.
Okay, thank you. Let's move on to management. What's the mainstay of management of syncope?
A lot of that depends on what the patient's background, what the patient's past medical history, and the description of your event and what you find. So assuming you do an EKG and your EKG is normal and you get a history and it sounds like they had a vasovagal event, they were urinating, they passed out during urination, and they have no other medical history that suggests that they should have that this should be a worrisome syncopal event, such as they don't have a history of left ventricular dysfunction, or congestive heart failure. They don't have a history of valvular heart disease, and they just simply they stood up and and passed out. Or they stood up and while they were urinating and passed out, and their workup is negative. Those patients can go home. That's the extent of